So that means, where are we now? Where we are now is the upper extremity. We have everything from the sternum. There we go. Down to the fingers. Bilateral. And what's really cool is that we have this very unique dynamic system, this very unique dynamic structure. Everything down to the fine motor control of the fingertips, all the way up through the strength that exists in elbow flexion. All of this system hangs on one joint. As you get the humerus up into the glenohumeral joint, you peek in here and you'll see that that scapula is floating. There's nothing attaching it ligaments-wise. If I pull out the muscles, there's nothing sitting there that holds it in place. It's all muscle. We have this one little joint sitting right in here that takes every bit of strength and power that the arm produces to connect it to the scapula, and then all of that motion is connected through the AC joint. This one tiny little joint. And then we can step it back even further because the axial skeleton starts with the enclosure of that thoracic cage at the sternum, to where that clavicle is actually beginning at the sternoclavicular joint, the SC joint. So where you may have a SC damage or injury, you may have a broken collarbone, or you may have a damaged AC joint, that is the separation of the entire weight and force production of the upper extremity to the axial skeleton. There's a tremendous amount of load put through there. So let's pick apart some of these structures because it's really kind of strange and unique. Sternoclavicular, let's grab clavicle. Peer into it for a moment. So in this view, you've got a right side clavicle, and you'll see you've got this bowing, this convexity on the first 2/3. And you can feel that. Grab it on yourself. Make it real. So find that sternum. Find that SC joint. And palpate that around. Feel that bowing outward. And then when you get to about that 2/3 point, right in through here, it switches direction like it's an S, and it drops into a concavity. So it's in that middle third that we tend to see most of our injuries, because it's the most exposed. But it's also this shift from a convexity to a concavity, which means that there's a weakness in there. Now that bone has got, on one end, on the sternal end, it's kind of bulbous and blocky. And on the distal end, on the acromial end, it gets flat and smoothed out. So if I'm holding on to a clavicle, look at it oriented to where 2/3 that convexity is facing anteriorly. Flip it whichever way you need to make the bulbous fat end towards the middle. From that point, you've got a couple little landmarks on it. On the underside of it, distally, there's a groove for a couple ligaments. So looking out from underneath, we've got 2 ligaments that sit up from underneath to hold it down. And then in the middle here, underneath, add some muscle that takes them up. We have the one muscle that's connected to it directly to create motion at that muscle, on that bone, across the sternoclavicular joint. It's conveniently named the subclavius, under the clavicle. So it's not a hard, tricky thing. And it's geared to help create depression, pull it back down. But at this point in the conversation, the only thing I want you to really write down is that outside of that subclavius, there isn't another muscle. There is not another muscle that directly controls motion at this joint. Or at the AC joint for that matter. Next one out. So what does that mean? That means that where in the past we have taken a joint and we talk about the bones that make it up and the ligaments that stabilize it and the motions it can go through, at this point, we don't have muscles to create those motions. So how do we create that motion? And it's, interestingly enough, it's coming from distal. May I see your hand, please? Good. So if I want to raise up his shoulder, I could put pressure on his wrist to the point that he gets uncomfortable. Then he'll do things to prevent it from getting worse, which is bend the elbow to leave pressure. If I want to lift up his shoulder, then I can keep going. I'm creating motion by putting the pressure and keeping the pressure here at the wrist. So the shoulder is going to be the same way. The muscles over the shoulder are going to put pressure on the scapula, which put pressure on the clavicle, which create the motion. So the stability is going to come proximal to distal. The mobility is going to come distal to proximal, pushing it up each way. So we're going to talk about this several times, but we'll get in depth with it next class more. Because this is just like the screw-home mechanism, just like the windlass mechanism. We've got layers of conversation in here that are a little bit more conceptual rather than just straight memorization. Okay? So we want to go back and we want to focus on that core structure, proximal to distal, and then we'll come back and do mobility. So, sternoclavicular joint. Bulbous end. It's actually a saddle joint. It has a joint capsule. That joint capsule, as we've discussed other times, the reinforcements, the thickened areas of that are two of our principal ligaments. I think somebody's making one of my skeletons dance over there. Guy in the middle. Skeleton in the middle. So give them dancers. Oh. Sternoclavicular joint, anterior and posterior sternoclavicular ligaments. So the joint capsule itself is reinforced on the front and the back side, helping this clavicle stay away from shifting anterior and posterior. The next two are not so kind from visible body because they leave them off. Oh well, send them a hate mail. How dare you? So there's a ligament that runs across. What's this bone called? Sternum is the big name. What's this piece? Manubrium. Yeah? All right, so manubrium here. We've got an interclavicular ligament that goes in between the clavicles. It connects right to left. It goes over the top. What's that space right in the middle? What's that indentation off the manubrium? Jugular notch. So, interclavicular ligament running right across and through here. And then our last one is costoclavicular. Costo, rib, clavicle, costoclavicular, connects the rib to the collarbone, to the clavicle. So it's in the costoclavicular that we have the first bit of this conversation. To hold the clavicle in place, it's tethered. It's held down. It's held from underneath directly, just keeping it here. Because this, yeah, we need this stable, but again, with that mobility stemming from external, from distal, and coming more towards the proximal, there's a series of tethers that are going to come in to help hold it up. So this costoclavicular is the first of those tethers, one of the ones that stabilizes the SC joint. We step out laterally, get it past my costoclavicular. So saddle joint gives a little bit of stability. That clavicle off that first rib will elevate as much as 30 degrees. We've also got some forward roll, posterior roll. If you can feel that moving underneath your fingertips as you shift your shoulder, as you put pressure. You can tilt it forward some. The biggest motion, though, is going to come off of that elevation as you go into abduction. Then distally, we get into the next joint, which is your acromioclavicular. Again, it flattens out at the distal end. So you can see how narrow it gets versus this big bulbous proximal point. And we've got this junction, the clavicle, as it flattens out, as it comes in with the acromion. So that's the spine of the scapula that reaches around and flattens into meet its neighbor. So the acromion butts up right next to it, kind of comes around its side, flanking it, and the clavicle just touches right up against the side. This is a gliding joint. Now put that in perspective of what it's doing. We have the weight of the entire upper arm, the musculature, and everything it does, including any kind of resistance we put on it by lifting, pulling, pushing, throwing. And all of that is transferred through a gliding joint that is directly side by side to what it's touching. If I'm going to go and try to lift something, stabilize something, hold something up, I tend to want to be above it. Like, this is an awful arrangement. To put that kind of load in through a gliding joint. So the acromioclavicular joint capsule, that really is the acromioclavicular ligament. That stability then is coming from a different location. So scapula has this cool little finger-like projection that slides forward called the coracoid process. And that clavicle comes directly above it and tethers to it. So the stability of the AC joint, of the acromioclavicular joint, is not coming so much from that AC joint itself, but rather the proximal tether that's holding it to the coracoid process. So it looks like your main attachment point is that joint, that gliding joint above, but rather it's more of the tethers of this coracoclavicular ligament stabilizer. Now there's two pieces, there's two names, there's two parts. One's the trapezoid part, it's the more anterior, one's the conoid part. So in that conversation, we also begin to say, you know, we had a tuberosity before. Tibial tuberosity, what attaches to it? Quadriceps. Quadriceps attached to the tibial tuberosity. So tuberosity is like a bumpy reinforcement. It's an attachment place. If I have this cool little projection of a bone coming up in here, it's because things are attaching to it. It's there for a purpose. The scapula is one funky shaped bone. And every bit of it is used. Coracoid process has as many as 7 different things tying into it. So in your mind, you should probably go, and the guy likes lists, and select all that applies, and so you might want to start making that list. So coracoclavicular ligaments are the first of that. There's those two parts, conoid and trapezoid. Coracoid process. Now, we have multiple guess exams, multiple choice exams. So you're not spelling too much more. But in terms of spelling, this is one of those times that it makes sense. It makes not sense. It's imperative to start figuring out the way to spell it. You misplace a letter, and all of a sudden you get different anatomical structures. So we have the coracoid process. We have the conoid part of that ligament, very close to the spelling. If you get to the elbow, we have the coronoid process. Coronoid, coracoid, there's a whopping one letter difference between them. So just keep things separate. Keep things straight in your head. So gliding joint, AC, you get about 30 degrees of elevation off of it as well, except it's coming from the humerus pushing up into that acromion, which then pushes it into elevation, to push that joint to where it should. And what prevents it from coming up is not so much this joint capsule here exactly, but more the tethers that come up from underneath. So injury's sake, there's an acronym you'll learn. It's FOOSH, F-O-O-S-H. Fall on outstretched hand. Off a bike, on skateboard, or walking your dog, getting tackled, whatever. Fall on outstretched hand. You do that, it's creating an axial load up your system. This is a great way to damage your AC ligament, your AC joint. There's a half a dozen other different injuries you can get from broken forearms and everything else in doing a FOOSH. So you'll learn the term. It shows up when in doubt, guess FOOSH. Now, the other way to damage this, though, is if you tuck that arm in and fall and hit point on, you're driving that force directly into the side of the acromion, which is further going to damage that ligament. How are we supposed to tuck and roll? Don't fall. Just be better than that. Don't let gravity get you down. Okay. So what's that injury look like then? I mean, clearly we're going to injure this, but if that's not the principal stability, then what else are we doing? And that's when we start having some fun, because if you start stretching out these guys, then that clavicle starts popping up because we stretch the ligament that's holding it down. It creates this cool thing called a piano key sign. What happens when you push down on a piano key and then let go? It pops back up. Go give me a grade 2 AC sprain, AC separation, and it'll pop up. You push it down, and it'll pop back up. Yep. They're not going to like you very much. Grade 3 means that we have a full rupture through here. There are grades 4, 5, 6. Those are actually looking at different fracture sites that are breaking in and around in different locations. Once you hit grade 3, that person's easily getting referred off to get eval by to make sure none of the other stuff is going on. But the key points you need to pay attention to is that this clavicle coming through, again, the saddle joint here is some stability. That first tether of the costoclavicular ligament is helping to hold and to keep it in place. And then you get quite exposed when you get out to the distal end. That acromioclavicular joint has that 30 degrees of tilt of motion, but it's really coming from this coracoclavicular tether that stabilizes it. Beyond that, we get to the glenohumeral joint. Just rotate you a little bit. Now we'll pull off some ligaments, or maybe the entire scapula. Try to put that piece back. Get rid of ligaments first. All right, so first things first. Ball and socket joint. That humeral head is massive compared to that glenoid. So the articular surface of the glenohumeral joint on the proximal side is small. And it's not very deep. Compare that to the hip. What's the articular surface on the hip, on the pelvis side? The acetabulum, right? Then we have the femoral head that sits fairly locked into a bony cage. And some ligaments that band around which make up the joint capsule. Which is more mobile? Glenohumeral or the hip? This one moves a lot more. Good? Which one's more stable? Hip by far. And I have that bony outreach around that femoral head, holds it in place. It cuts off some of the angles it can go, but we get so much of that back when we look at the glenoid, but we get that back and lose a lot of the stability that can go with it. So, reinforcements of the joint capsule. Joint capsule around the glenohumeral, we have a superior, a middle, and an inferior glenohumeral ligament. Give me a big ball sitting on top of a dinner plate. And if I go and abduct, that humeral head rolls upwards. Big ball is then going to roll off a little dinner plate. So there's got to be something going on that helps. There's accessory motions that exist to help make sure the system works right. For every bit of roll, we have to slide it. We have to translate it downwards. So as it's rolling up, it's also sliding downwards at the same time. So the reinforcements, that means that this inferior glenohumeral ligament, which is kind of like a sling, like a hammock, it cradles underneath it. As I abduct and that humeral head goes up and it's sliding downwards, it's actually my inferior glenohumeral ligament that restricts that motion. Now, this is a concept that you'll need to work through. Not so much now, but by the time you get to rehab class, because when you get to rehab, we use a lot of joint mobilizations. We have to pay attention to the motions that we're putting stress on to get mobility back within some ligaments that might be tightening up the joint capsule that we need to kind of loosen. So getting a grasp on that translation conversation is going to be something that you'll see again. But it's very, very important here with the shoulder. If you can master the shoulder, it typically makes that joint move conversation a whole lot easier. So superior, middle is going to protect. Well, what is middle protecting? If inferior is keeping me from going into abduction. What is this middle glenohumeral ligament resisting? Well, let's describe what is that, because it's not a term we've really used before. What is this motion here? What plane is it? What kind of transverse plane comes through here? We've usually tied that transverse plane into rotation, but that's not so much of what's going on here, right? And rotation, well, rotation is more here. So what is this motion? So it's an adduction, abduction, but in the horizontal instead of the vertical. So it's horizontal abduction, horizontal adduction. All right. So if we go and horizontally abduct, that humeral head is rolling backwards, and it's having to slide forward at the same time. So the middle glenohumeral ligament is preventing me from going. So it is the one that's resisting that horizontal abduction. So with the shoulder, it's kind of the opposite side as the direction of the motion. All right. A couple more ligaments. Coracohumeral, from the coracoid process to the humerus. Add that to the list of things that attach to the coracoid. And then we have this guy, coracoacromial. This one entertains me. Why is that? Why is it weird?
Just to the same.
Connecting one bone to the same bone. I mean, the coracoid process and the acromion process are both outstretched margins of the same bone, of the scapula. So we have a ligament that's going from the same bone to the same bone. Now we've seen that with the hip. We've seen that when we have like the greater sciatic notch, and we have sacrotuberous, sacrospinous, and helps kind of split some of these big curvatures. We don't really have that big curvature quite so much here. So what's it doing? It's not crossing bone to bone. How is it stabilizing this joint? Why is it? How is it necessary? Yeah, so it's going to help limit that humeral head from rolling up and out. It's going to create a roof that we're going to push up against. It's kind of like that acetabular that reaches out to kind of surround. Well, we don't have the glenoid doing that, but we do have an extra piece that reaches out over it, so when we go up, it stops it from going out. Now, it's also creating a superior protection. So this is called the subacromial space. There's this gap in through here. And I guarantee you there's not a big open air gap in that space. There's soft tissue, there's soft squishiness all through it. So supraspinatus muscle, long head of biceps, there's a bursa in there. So we'll come back to those, but that space is filled up. And this is helping to create a rigidity that helps protect that from being damaged. But more so, it's helping to hold that humeral head in place. All right, so I'm going to pull you off. Add some muscles back in and keep a couple muscles off. Okay. Let's do on your shoulder. We'll start here. I want you to find the humeral head. So if you go from the top down, you should be able to feel the furthest out point of your shoulder, which is the acromion. It's this point that reaches right out here. And so just below it, you move and you can feel that humeral head. You can put your finger right in that gap underneath where that humeral head shifts. So from that point, straight down, you've got kind of a big bump on the outside of your humeral head. That's your greater tuberosity. So it's a nice big ridge line through here, which is going to be an attachment point for a couple muscles. So palpate forward to the anterior presentation. And what I want you to do is rotate your arm in and out. Rotate it, internal rotation, external rotation. And you should feel right in this space through here that there's a little bit of a shift, almost like you're going over soft tissue. If you don't feel it, let me know. But that soft tissue is this right here. So greater tuberosity, lesser tuberosity. And there's a groove right in the middle. And that groove, in it sits the long head of the biceps, which is what this is. So the ligament that I want you to focus on is that guy right there. The transverse humeral ligament. We've had retinaculum down in the ankle that helped hold tendons in towards joint spaces so they don't bowstring up. Well, this is a tether. This is a stabilizing support to hold that long head of the biceps down against the bone, regardless of the angle of motion or the direction of pull. The last one that we're going to touch on. If you look at the scapula from the back, you'll notice that you have this tiny little hole up top. There's like this little divot. And all of our guys have been here. Eyes deep and upside. Deep and upside. Suprascapular notch. Supra above the scapula. Suprascapular notch. It's a notch. There's a small ligament that goes over that too. That little dude right there. So the transverse scapular ligament. Now through that hole is the suprascapular nerve. So we have both a protection by having a taut ligament over that space, as well as a tether to hold that nerve in that little groove. Okay, so one thing I want to play with at this point is putting your hands on these structures to kind of feel them. So let's do partners. Now I want one person seated and I want the other person standing behind them. Wait a second.
What's up, Justice?
All right. So I want you to start with just taking your hand and resting it over the shoulder. So your fingertips should then sit right about the level of their clavicle. The curve of your hand should feel comfortable just falling right across their shoulder. Good. Now, palpate the clavicle. Palpate that collarbone. I want you to feel that convexity in the first 2/3, the concavity in the distal third. Palpate it anteriorly so you can feel the SC joint. Many of us don't have perfectly aligned spines. Many of us have some rotations in our body. It can get much more pronounced with individuals when you start looking at any kind of lateral shift or scoliosis. But that can present in one sternoclavicular joint, one clavicle being a little more pronounced than the other. And so feel for that. I want you to kind of get your fingers on the SC joint on right and left side and seeing that they're even. It's just a visual, when you're looking at someone, a visual assessment of indications that a posture might be off or that your leg might not be stacked perfect. Now have them abduct. And I want you to feel the elevation and where that elevation is in the clavicle. When does it start going up? Have them roll that shoulder forward and feel that thing shift anteriorly. It's crunchy. All right, now take your fingers, trace them out towards the distal end, and I want you to find the AC joint. This gets to be a little bit more difficult because it's not as pronounced, but where you've got that acromion reaching around and the clavicle butting up against it, if you get them to abduct, you can get the tilt on the acromion to where you can feel the angle on the AC. So you follow that, the proximal 2/3 are convex, distal thirds concave. You're going to get near that end. And then you're going to find that little bit of a gap between the acromion and the clavicle.
What? Don't eat. I don't like your haircut either. Come on.
All right. From that AC joint, you take your finger down and over. Take it past that acromion to where we were before, to where we had the greater tuberosity. And you could feel that space that demarcates the glenohumeral joint itself. Now, get it that this humeral head is underneath. So we're not getting anywhere near the glenoid. So everything about the glenohumeral articulation is deep and protected. But you can get your fingers off to start feeling for where the joint capsule will be. And if you spin your person around to face them, and I want you to cradle the arm right through here, where you can kind of grab on that elbow. So rest the forearm on your forearm, grab the elbow. And then I want you to find, so let him bring it down, So let him keep it on the side. So here, bring your shoulder up. There you go. Just cradle it there. And I want you to palpate down to find that joint space. So you pull down inferiorly. So we're going to distract the humerus. We're going to distract the humerus away from the scapula. You can feel some of that shift. You can feel some of the tension as you pull the humerus down and away from the glenoid. Now there are some who have some significant joint laxity. And when you pull a lot, you can actually see quite a bit of it.
Hey, how are you doing?
So, yeah.
It's both legs.
Shredded. It's because he does. Hey, it's because he does shoulders all the time. So no way. He's too big. They say in Spanish. They say you're big in Spanish. You're head, right?
Neutral. I'm big. I'm big.
Mama or mama.
Now, this is not the position I would want to typically do this with somebody. If I get them lying on a table, they're more relaxed. And then I can play with that shoulder a whole lot more. But we're looking for something called multidirectional joint instability. We're looking at how much stability is coming from the joint capsule itself. Because if we have significant damage, this thing is going to get looser and looser and looser. Or if we've separated the labrum because we pulled it off the bone, then we're going to feel a lot more laxity, a lot more slippage, a lot more mobility. All right.
Big guy.
Good. So, next thing is this scapula. It's shaped the way it is for the sake of having as much attachment points as possible. So we need to orient ourselves with more of the terminology that define osteolandmarks. So first things first is we got to find it. Now some people are much easier to work on than others. The less musculature, the less body fat, the easier it is to get down to the bone. So we got to find a way to get this thing to present to us, especially when there's a lot of stuff in the way. So take the hand, internally rotate it, and 80 does. Just tug it in and out, and that'll present. You can see how much more of that scapula has presented itself to us here. So clavicle, a C joint that gives us the acromion. We can track that acromion around for the spine of the scapula. Now the spine of the scapula, if you remember back when we were doing spine stuff, we kept taking the trapezius muscle and resecting it. So we go occiput through T12, and that fan shape all blends into that spine of the scapula. So origin, occiput T12, it inserts across that spine right there. So if he does a shoulder shrug, then we're going to get this nice little patch of trap sitting right up in there. Now underneath that, deep underneath that, we have this groove, we have this space. So we followed acromion into spine, and above it, we have this fossa called the supraspinous fossa. Supra, above, spine, above the spine of the scapula. Fossa, from the leg. Find that spine, well, then sitting in that spine, fitting in that supraspinous fossa is the supraspinatus muscle. Spinous scapula, and then we go below it, infra. And infraspinous fossa is this whole spot down through here. So with it presented this way, you can actually very easily get your hand to kind of sculpt this angle right through here. So where that inferior angle is fitting right in your fingertips. To where that inferior angle is fitting right in the webbing of your thumb. So from that inferior angle, you can palpate medially to find the medial border, which takes you up above the supraspinous fossa to the superior angle. You can then find inferior angle and come laterally to find the lateral border, which then flares out into the glenoid. And on some folks, not so much here, but when it presents a little bit, you can actually get under that medial border where you can grab to the subscapular fossa, where you come in through here to get to the subscapular fossa, which is this surface down here. Good? So orient yourself with the landmarks on the scapula, because again, as we go into origin insertion, that is the language of origin insertion. So there are 4 muscles that we're going to jump into real quick that eat 75% of the land mass of the space of the scapula. So rotator cuff. You've all heard of rotator cuff. 4 muscles, right? S-I-T-S, sits. The first of them, S, supraspinatus. Supraspinatus. So we have the supraspinous fossa. And sitting in this groove, sitting in this chasm right here, is the supraspinatus muscle. Supraspinous fossa, supraspinatus muscle. Nice and simple. Now this one's a little tricky because it's going directly over the top. So it's filling in, if you recall, that subacromial space right there. So right in here we have that acromial, the coracoacromial ligament that finished off that roof, the acromial process. So that subacromial space, I said there were soft squishies in there. That's the supraspinatus muscle. It's the biggest component in that space. But because it's going directly over the top, it's less rotator, and more so it's more abductor. So it's grabbing. It gives me like the first 15 degrees of abduction. Motion. It initiates, it assists in the initiation of that abduction. Now, if I internally rotate, it's then got line of pull to create external rotation. So eccentrically, it's going to facilitate external rotation. So it's going to slow that down, which is what you should think of every time you hear of eccentrics. So first S, supraspinatus. Anyone want to guess what the I stands for? Infraspinatus. We have the supraspinatus fossa, we have the infraspinatus fossa. This is the infraspinatus muscle. So supraspinatus is right here. Find it up top, filling in that groove. Infraspinatus is sitting right there. So it's filling in the majority of all of that infraspinatus fossa as it reaches out and it inserts into the greater tuberosity with the supra. And then just below it is teres minor. T-E-R-E-S, minor. And this is coming off about the middle part of the lateral border. So if I kick off this, you'll see teres minor just covering up that lateral border right across that middle section. Now, infraspinatus and teres minor, they're reaching around from the back and they're going to pull me into external rotation. So that leaves the fourth, the last S. So supraspinatus, infraspinatus, teres minor. Then we flip around to the other side. Kick off that one. Hip minor. We get this window of a view where we can see subscapularis muscle coming from the subscapular fossa. So far, these are like the nicest group of muscles you've ever had. So subscapularis is coming from the anterior presentation, the anterior surface of the scapula, the subscapular fossa, reaching forward and underneath to grab onto lesser tuberosity. So if you put your finger back on the greater tuberosity in the anterior and you're going back and forth, you're going to feel that interspiritular groove where long head of biceps is sitting. But that more medial presentation, that's your lesser tuberosity. That's the insertion of subscapularis. So face your buddy, face your partner. I want one person to be rocking soccer robots right in here.
All right.
Your elbows at your sides, and hands out in front.
Definitely forgot.
And I want you to put your hands on the outsides of their fists. Outside. Good? So put your hand on the outside. I want my clinician to push and try, well, to attempt to push the hands together. I want my robot, my rock and sock and robot, to prevent that from happening. So you stay put and don't let them push you in. So this is resisting external rotation, right? Who wins?
Me.
The clinician or the robot?
The clinician.
The clinician's going to win 9 times out of 10.
And then you start.
Now, go back to that starting point. Move your hand to the inside so you're pushing outward. Try to pull them apart while they push in. Who wins?
Pull them apart while they push in?
Yeah, exactly.
Like this or like this?
Robot does a lot better that time, doesn't it?
Like
Which is stronger, internal or external rotation?
Don't let me push out.
Okay. So we've got internal rotation is stronger.
100%.
How many muscles create and stabilize external rotation? 2 to 3, right? Teres minor, infraspinatus, supraspinatus. Ish. But internal rotation, I have how many muscles? 1, subscapularis. Why is it that I have as many as 3 muscles for external and it's weaker significantly than internal rotation with 1 muscle? Why does that make sense? There's only 1 muscle creating internal rotation. Why is it stronger?
Where it's at? Where it's located?
Nope. Bigger, bigger, about the same size as interesting.
It's levered.
You got it. What you got? Say it to George. George is
You got it, George. For pro.
Why am I stronger pulling in here? Why am I stronger here? Am I right in saying there's only one muscle?
No.
What muscle is there that supports in this position? Pec major is right here. Pec major grabs right across and pulls directly in line with that. So when I'm here, it's not just subscap. It's subscap with pec, and pec major is huge compared to my rotator cuff. All right, so what I want you to do is find your buddy again. And so abduct the elbow right here. I want you to support the elbow with one hand. So shoulder at 90, elbow at 90. And do the same thing again, except I want you to have them do internal rotation this way and external rotation this way. So they're pushing down, they're pushing up. So try that push, push. Push to my hand. There you go. Push. Push up. And all of a sudden, external rotation starts winning. If I take out the line of pull in pec major, then my 3 can overpower the 1. Make sense? A little bit more. So like we did with the hips, where there's a whole bunch of synergism, like the piriformis is, the sartorius is helping with a little bit of everything. It's the same idea. Joint position will influence which muscles that we're playing with, we're testing. All right.
Next year.
You could use it.
Oh yeah, I'm dropping out some good.
So here's what I want. Well, this is about as far as I got scored there.
I think we're doing
Okay. Your goal this week. Work on joint structure. Work on the ligaments to stabilize each one of them. Go back and go through. If you go back, you've got that osteo landmarks page. Start working on the osteo landmarks page so that you're comfortable with which landmarks we're playing with. And that you're working on that language so that origin insertion becomes easier. Familiarize yourself with points of attachment. And if you need to find time to come chat with me, find time to come chat with me. That's enough for me.
The remix.